A comprehensive assessment generates a massive volume of raw data. The diagnostic phase is where you take that scattered information and organize it into a coherent clinical picture. The formal diagnosis of mental and substance use disorders is a legal mechanism reserved for qualified professionals. As a counselor, your scope is distinct, the 11 criteria for substance use disorders outlined in the DSM-5. These 11 criteria map to 4 conceptual clusters: impaired control for excessive use, social impairment for failing obligations, risky use despite harm, and pharmacological for tolerance or withdrawal. Count determines severity. 2 to 3 is mild, 4 to 5 moderate, and 6 or more severe. By accurately recognizing these exact criteria and calculating their count, you establish a precise clinical baseline. That baseline ensures the client is matched to the exact level of care they actually require. Because trauma is heavily prevalent among individuals with substance use disorders, screening for it must be a universal baseline in your intake process. You do not wait for a client to volunteer a trauma history. If trauma goes unrecognized, the clinical consequences are severe. Unaddressed trauma directly drives poor engagement, premature dropout, and a high risk of relapse. The screen specifically targets active psychological markers. You are looking for depressive symptoms, persistent sleep disturbances, and past or present mental disorders. You also map the historical and environmental context. This includes noting the characteristics of the trauma, the nature of their co-occurring substance use, and the current state of their social support and coping resources. Simultaneously, you must evaluate acute risk factors. The screen specifically checks for any potential for self-harm, suicide, or violence. A positive trauma screen requires an immediate operational shift. It triggers a fuller, dedicated trauma assessment and mandates that a trauma-informed approach is applied throughout the rest of their treatment. Executing this requires strict clinical tact. The simple act of asking a client about trauma can trigger severe distress, forcing you to balance your need for clinical information against the client's current emotional stability. Under no circumstances do you push a client to disclose more details than they are prepared to share. Establishing the client's safety and emotional readiness during the screen is a strict prerequisite. Without that foundation, subsequent treatment interventions cannot succeed. Statistically, roughly half of all people presenting with a substance use disorder also experience a co-occurring mental health condition. This requires a major diagnostic caution. Acute substance intoxication and active withdrawal can perfectly mimic the presentation of independent psychiatric disorders. Depending on the substance, a client in withdrawal or acute intoxication can present with severe anxiety, deep depression, mania, or even active psychosis. This dual-axis timeline charts a client's severe psychiatric symptom presentation against weeks of prolonged abstinence. This longitudinal observation is your primary tool for disentangling the data. If we observe a steep drop in psychiatric symptoms as abstinence continues, the condition is classified as substance-induced. These symptoms typically resolve on their own once use stops. However, if the symptoms persist steadily despite ongoing abstinence, the data confirms an independent co-occurring disorder that requires its own dedicated treatment track. Attempting to lock in a diagnosis prematurely during the acute intoxication phase risks severe clinical errors. You will inevitably overdiagnose temporary states and underdiagnose hidden independent conditions.
Within your scope, your job is to screen for these conditions, refer the client out for proper medication evaluation, and coordinate care across different medical disciplines. Separating induced symptoms from independent disorders protects the client from catastrophic misdiagnosis and guarantees that each distinct condition receives stage-matched, appropriate care. The second major diagnostic caution addresses clinical interpretation. Behaviors commonly labeled as resistance often function as clinical symptoms of an underlying disorder. Clinicians frequently mislabel difficult behavior as simple denial, active manipulation, poor motivation, or just a bad attitude. If you look closer, those behaviors map directly to true clinical origins. What looks like a bad attitude may be the flat affect of depression. Seeming manipulation is often the hypervigilance of post-traumatic stress, and poor attention maps to the impulsivity of ADHD. This recognition changes your immediate therapeutic response. You stop confronting the behavior and start investigating the clinical mechanics driving it. Measuring apparent resistance as clinical data prevents you from alienating the client, ensuring you treat the actual disorder rather than punishing its symptoms. During a comprehensive assessment, you have a high probability of surfacing histories of child abuse and neglect. You have a proactive obligation to screen for these issues, particularly concerning any children currently under the client's care. Suspected current child abuse or neglect triggers a non-negotiable legal and professional duty, mandated reporting. When a disclosure occurs, your professional conduct must be exact. You handle the information without shaming the client, document the facts objectively, and follow all required agency reporting procedures. Mandated reporting legally overrides clinical confidentiality. It is a hard, strict ethical boundary that defines competent practice. The diagnostic phase acts as a precise sorting mechanism. It draws a clear line between what your program is equipped to treat and what requires an immediate external referral. Acute, high-risk psychiatric presentations, specifically active psychosis, acute mania, or a significant risk of suicide or violence, mandate immediate external intervention. Similarly, severe medical conditions requiring physical care, the need for specialized medication evaluations, or any diagnosis outside the legal scope must trigger a referral. Identifying these triggers and connecting clients to external services represents a core clinical competency and a proactive step toward meeting the required standard of care. Setting clear referral boundaries ensures highly complex medical and psychiatric needs are met and do not fall through the cracks of the broader healthcare system. All gathered data is ultimately synthesized into the diagnostic summary. This document is the narrative bridge organizing raw assessment facts into a usable clinical logic. A strong summary contains mandatory components. It states substance use severity, identifies coexisting psychiatric conditions, lists client strengths, and dictates specific treatment priorities. The summary has strict parameters. It must avoid clinical jargon, refrain from prioritizing interpretation over observation, and never state conclusions raw data doesn't support. If the assessment identified any external referral triggers or specific medical conditions, they must be explicitly named within this document. A disorganized or vague diagnostic summary directly yields a vague, ineffective treatment plan. A clear, explicit summary sets the exact parameters for focused care. The ultimate goal of the diagnostic phase is to weave trauma screens, co-occurring complexities, and reporting mandates into one unified vision of the client. Executing this phase with rigor and clear boundaries produces the accurate, integrated understanding required to build a focused, highly individualized treatment plan.